I'm Dr. Rachel Drew from the Internal Medicine Residency Program at the University of Tennessee, Chattanooga, and here I'll be presenting a neurovisceral mystery, diagnosing acute porphyria. Here is poster representation of my case report, of which I will be going over in the next few slides. Porphyrias are a heterogeneous group of rare, often underdiagnosed disorders caused by enzymatic defects in the heme biosynthesis pathway, resulting in accumulation of neurotoxic porphyrin precursors. Acute porphyrias, such as acute intermittent porphyria, typically present with nonspecific but severe neurovisceral symptoms, including abdominal pain, peripheral neuropathy, and encephalopathy. The differential diagnosis is broad and includes infection, autoimmune disease, metabolic dysfunction, toxic etiologies, and all of these necessitate extensive diagnostic evaluation and workup. The workup for peripheral neuropathy often involves nerve conduction studies, serum CSF, vitamin levels, and autoimmune panels, while encephalopathy evaluation requires neuroimaging and metabolic testing. Often, lumbar puncture is necessary to exclude infection or inflammatory causes. Ultimately, diagnosis is confirmed by detecting elevated urinary porphobilin levels during acute attacks. The management involves removing triggers and treating symptoms symptomatically. And sometimes administration of hemin is necessary to downregulate hepatic ALA synthesis. Early recognition is essential to prevent irreversible neurological damage. Here's the case presentation. We had a 26-year-old female with a past medical history of alcohol use disorder, prior ankle fractures, status post-repair within the past 3 months, presented with visual changes, peripheral neuropathy, which was very severe, autonomic instability, and motor dysmetria. On presentation, she was acutely encephalopathic, dysuric, and in a state of shock. She was initially admitted to the ICU for stabilization. Surprisingly, her labs were largely normal. Electrolytes, liver function, kidney function, heavy metals, urine toxicology were all normal. She did have a notable anemia and a ferritin of 100, but most other labs were normal. Imaging was also relatively benign, with a chest, abdomen, pelvis, CTA, and spinal MRI showing no acute findings. A brain MRI did show some parenchymal volume loss greater than expected for age and minimal periventricular T2 hyperintensities. However, still no signs of acute infection or autoimmune disease. An LP performed showed normal protein, glucose, and cell counts. The opening pressure was also normal. An ophthalmologic evaluation showed no papillary edema. An autoimmune encephalitis panel was also normal. Autoimmune labs were normal, homocysteine levels were normal, and there were no signs of heavy metal toxicity. Given persistent multisystem symptoms, finally, porphyria levels were sent, and there was marked elevation in coproporphyrin 1 and 3. Throughout hospitalization, patient was symptomatically treated and showed dramatic improvement in her clinical picture. At time of discharge, she was recommended to follow up for further genetic testing. In conclusion, acute porphyrias are rare but serious diseases. They pose significant diagnostic challenges because of their nonspecific symptoms that can mimic numerous other conditions. While uncommon, it is important to consider porphyrias in unexplained neurovisceral syndromes. In this patient particularly, contributing factors to this diagnosis may have been the alcohol use disorder as well as her severe iron deficiency anemia. Ultimately, early diagnosis is imperative for preventing irreversible damage. Finally, prompt treatment from removing triggers to initiating hemin therapy and symptomatic management is important to improving patients' overall care. With my works cited for this case report. Thank you for listening.